Thank you, Manish, for a kind introduction. Everything is clear?
Yes, sir, it is clear.
Okay. So there's a very interesting thing I want to share with you guys. And that is that now for almost 35 years, and I was shocked to realize that I've been working for so long. I have been going to small cities and towns of northern India and taking so many lectures. And yet we keep having streams of patients who are one-eyed, who have never been diagnosed as glaucoma. And I realized that something is wrong. Actually, in GSI also said that maybe our approach is not correct. And therefore I devised another technique, that is, you have to get the practitioners interested in glaucoma. Why should they work? Why do they want to do anything to do with glaucoma at all? They only want to do cataracts. And they says there's such huge numbers, sir. So what is the problem? We'll do cataracts only. Well, the problem is that there almost everybody in your town, in your place, will be doing a cataract. All ophthalmologists are doing a good job. Really, it is so rare now to see a complicated case. I'm truly impressed. Not only that, with the cataracts, there is so much of seasonal variation. So people will say, oh, sir, now there is a Diwali. Oh, sir, my children's exam. Now it is too hot. Now it is too cold. And yes, today only somebody told me, oh, sir, now, this is not a good season because the rains are going to come. In addition, there are charitable camps who are very busy taking off all your cataracts. So in that case, I think there's so many times where your systems are lying vacant. In addition to that, you know what this is? This is the biggest bugbear we are soon going to have. So you have now a femto cataract, and I can promise you that already half the job is being done. Soon somebody will invent 2 small tubes, and all somebody will do is to just press a button and the entire thing would be done, and inject a liquid lens in that also. You would be no one and totally out of the picture. So that will be very, very scary, but that time may not be far away. So please be careful. Please understand that glaucoma is something that each one of you in your practice must take seriously. And I'll tell you why it is such a win-win situation. You think it's a no-win situation because you are only seeing towards the surgery part, which I agree is extremely difficult and extremely unnerving. But how many patients today are requiring surgery? Barely 1% or 2%. And those two, you can always refer to a good center. Remember, in practice, a good referral will always bring you so many more patients. Even I refer at my level, and they always come back and say, no, sir, you have got the good of us in your heart, so we will come back to you with all our patients. Plus, there are too many collateral benefits. The first fact is, almost 1 out of 8 over 40 years of age, the patient has got either glaucoma or is a glaucoma suspect. 1 out of 8. It's a huge number. So I will not talk about millions and this and that, because you see 8 patients walking into your clinic, 1 of them will be like this. And cataract will get done and gone. But glaucoma patient is for life. So most of them, you have to sit down with them, convince them, talk to them for a long time. And then, every 2 to monthly, they will come for an intraocular pressure check. Every 6 to 9 months, they will come for a visual field check. Finally, they will develop cataracts as well. Not only that, they are not going to come alone. They are either coming with a younger daughter who may require a LASIK, or even a younger granddaughter who may require refraction, or some friend who may actually require a cataract. So think of the collateral benefits. The easiest thing is that we are taught enough. I bet that all of the postgraduates can actually pick up the glaucoma only if they put their minds to it. And most of the times they also know how to treat medically, but you have to be alert. You have to spend some time with the patient. And please remember, the most important thing is to create a visual impression. I can tell you my practice went up 20% when I started showing photographs to the patients. So you must show to them that, all right, this is a normal disc, this is a normal field, and then this is when you are having slight changes, something is going wrong, and we want to catch you very, very early so that you don't convert when your optic nerve is white. So this is things that they can understand. And then you have to explain to them that it is your duty to bring the rest of the relatives to me because they are going to be suffering from this disease. So this screening is, imagine how many patients or people will bring into your clinic. And it may be prudent initially not to charge their relatives, because they will think otherwise he's trying to make money. On top of everything, it must be clear that you are benefiting the patient and you are benefiting the society. The money will come, don't worry about that. So you may see them for free, but well, some of them will have this thing, something will have another thing, and then they will stick over to your thing. So it is a win-win situation for all three people, the doctor, the patient, and the relatives. And for us also, for the senior doctors, because I hate to see every day I'm operating a one-eyed patient. And that is what I hate to do. So me, Manish, Sachin, Rajul, we all are doing this day in and day out. So then the importance comes that the patient says, oh, this doctor is doing too many tests. You have to explain. After all, everything is hard-earned. And today in COVID time, every bit of money has to be spent wisely. So explain each test. Explain when you are showing them the visual fields, you have shown how it progresses. Tell them without this test, I cannot diagnose glaucoma. Tell them that we have to do repeatedly in order to know whether the medicine I'm giving to you is effective or it is not effective. And how much medication I require to give you is also depend on this test. So once you sit down and explain to them, they will not be averse to spending the money on doing that test. Again, pachymetry. When I go for lectures, a lot of people tell me, sir, we don't have the pachymetry. So, all right, you may have to send to somebody to get this corneal thickness. May not do it unless it's a case of normal tension glaucoma, because if it is normal tension glaucoma, it's a very thin cornea, then you know that you have to add some pressures. Or if it's an ocular hypertension, then it is important because you know that what exactly is the role of the thickness over there. Again, so all these things are important, but you have to explain to the patient. Gonioscopy is important because you tell them that if it is an angle closure, your chances of getting into problems, I would not say blindness to the patient, because the moment you say that you can go blind, the patient will completely lose it. I've seen so many patients get totally shattered and their lives are destroyed if you tell them that word. Anyway, many of them are going to go back and read the Google, and that can create a problem. So explain to them that please don't worry, you have glaucoma, there are only early features, I will take care of you. But explain that yes, you have to do these fields, we have to do the corneal thickness. I am doing a gonioscopy because it is important. If you have angle closure, we have to be more alert and we have to do a peripheral iridotomy, and you are going to earn money out of that also. So you have to be careful on that. Fundus photo, they are very, very happy getting done because you can tell them if you have diabetes, if you have hypertension, if you have anything else, this will also be documented in that photo that I'm taking for you, plus the disc will be documented. and a lot of progressions can be first caught on the disc itself. So very early changes, structural changes are some of the earliest changes to come up. So this was one of my patients in which the cornea was thick. The pressure was varying from 20 to 24. OCT was normal, field was normal. And I said, all right, let me just sit on this and observe this patient. And 1 year down the line, you see the patient comes to me, already there are changes. You can see there is a wedge defect and the field is still normal. So then you can explain, you can show all these things to the patient and tell them that, you see, I have to do an OCT because the OCT will pick up the changes much, much earlier than anything else. So he understands that every bit of money which is being spent is being spent wisely. And I bet that you can all look at the neuroretinal rim and you can understand that isn't rule is important. Inferior area has to be thickest, followed by superior, followed by nasal, followed by temporal, because that is how the fibers come. Though the rule may not be followed all the time, but by and large, it is very helpful for you to recognize that something is not right if it is not right. So as you can see over here, the inferior area has become thinner as compared to the superior area. And there's these dead fibers can be seen as a wedge defect, which if enlarged, we know that things are not going in the right direction. Same over here, you can see a normal neuroretinal rim getting thinned out. Again, the moment you see a hemorrhage, you can take a photograph, show it to the patient, and he will realize immediately, yes, they are really, really scared of a hemorrhage. So you must tell them that, please, we have to be more alert, more aggressive for this kind of a situation. As far as the size is concerned, very, very important. So many times I've seen that people are treating only large cups. So you must understand that anything between 1.4 to 2 millimeters is the normal size of the disc. And if there is a large cup, that is likely to be a part of a large disc. So you must measure the size of the disc, and that can be done with the help of a slit lamp, creating a light beam which will fit with the disc size. And if you're using a 90D, multiply it by 1.3, and you get the measurements by the size over there. So then you realize that, okay, now here immediately you will realize that, oh, this disc is very large. This cup is very large. We must treat this patient. Every day I get patients like that. Though the neuroretinal rim is good, though the isn't rule is being properly followed, though the fibers are all good, yet there is an asymmetry between the two eyes. So people will jump up. They will not see what is happening. They will forget, they'll do fields, OCT, which will all be normal. But then you see that the disc is so much larger in the left eye as compared to the right eye. And that is why it is showing you as a large cup. So it's all physiological. So this 12-year-old daughter came to me, a girl came to me with so many tests done and everybody crying, she has got glaucoma, treatment has been started. The first thing you need to do is make the parents sit down. Once the parents sit down, you find, oh my God, he's got a similar kind of a cup. So what am I doing? So be very, very careful. And again, if you have an inferior notch, like in this case, make sure that there is a superior field defect. Show this to the patient that you have a disc which is abnormal, you have a field which is abnormal and fitting into the diagnosis of glaucoma. So that is what always should be done. Again, now this may be absolutely normal, but if you see over here, there is a notch in the superior area. And if you see the visual fields, you'll find that this is represented as a step over here. Again, nerve fiber analysis is an expensive test. From various clinics, from 1,000 to 5,000 people are charging for it. Like I showed you previously, you have to use it judiciously. Classically, you should use it only, let us say, a case of ocular hypertension in which everything is normal, yet you feel that there may be some abnormality developing. Like the case I showed you before, if you do that, you'll immediately pick up that there are early changes and maybe I should start treatment. So like this case with the OCT had shown very early changes, and the moment year passed without treatment, the changes become progressive. So even when fields are normal, sometimes this you are not able to clearly see, this would be very, very evident. Now people say, sir, I don't have this machine. How am I going to do? I cannot do anything in glaucoma. And wait, don't lose hope. Identify 5 hospitals or single setups who will not keep your patient. They will send that back the patients to you, so you can send those patients for perimetry, fundus photo, and pachymetry. And the patient will have a feeling that yes, this man has a good faith in me, so he is sending me because for my good only, and they will definitely come back to you. Another technique which I called actually the indoor model because I learned it from there. 7, 8 ophthalmologists got together, got a common area, pulled in much lesser money by which they could buy all the machines. Otherwise, there was no way they could have done it. And put a common PA over there, and you can go in and do all the things over there. So in this era of corporates, if you want to fight corporates, group practice or a group thing like this could be a wonder thing. So what I wanted to tell you was you must develop a glaucoma screening. Even if you are a single practitioner, make them feel that yes, they have come to a specialist place where people can be caught. So 6 to 10% of walk-ins will be those who will have this. All relatives would be screened. Take time to explain, need for follow-ups. Always use photographs to impress them. Okay, enjoy a steady practice and don't wait only for cataracts. So I hope I've convinced you to put glaucoma as a part of your practice. Now let's move on and see what exactly is happening in the management part. So the people who are going to come after me are going to speak on combination therapy, and Sachin will speak on maximum medical therapy. So I'll just set the ball rolling for you. We know that medical therapy is the cornerstone of management. Yes, like I said, one part is only observation also. But by and large, most of the patients today are controlled on medications. Obviously, what we require from them is good adherence, persistence, because it's like BP. You know, you can't check, you don't know, nothing is wrong happening over there. That is why the importance of those photographs. The moment you show him a one normal photograph and one abnormal photograph, they will never forget. And then their adherence will improve so much more. The thing is that though intraocular pressure is not in the diagnosis of and definition of glaucoma, yet it is the only modifiable factor. So all the patients who have higher intraocular pressure have greater chances of developing glaucoma and getting progressions as well. And it is very, very important for us to identify which of these patients are fast progressors. So if the fields are dropping down rapidly, you have to be very, very alert, increase the medications, or maybe you may even have to go in for surgery in these patients. Younger the patient, more the fast progressor, you have to be very alert. So where do we want to keep their intraocular pressures when they first come to us? We have diagnosed glaucoma, we have done their disc evaluation, we saw something was wrong, we did a visual fields, we did a corneal thickness, we did a gonioscopy, we found it was open angle, or if it was angle closure, we did a peripheral iridotomy. Then we did a fundus photograph and a OCT if required. And then we move on to medication. So normally for a patient, there are a number of things given that OSTS go 20% low, normal tension go 30% low. But by and large, what I would say is that if there are early changes, please try and keep the pressure below 20, preferably around 18. If it is a moderate field damage or it's a one-eyed patient, better keep it around 14 to 15. And if it is an advanced field, then have to have a pressure as low as possible, preferably around 10. But this is the primary thing. This is the pressure that we have thought we'll fix up. Then we will repeatedly do visual fields. If it is an ocular hypertension or mild changes only, then we'll do the visual fields after every 6 months to 1 year. If it is an advanced damage, we will do fields maybe every 3-4 months to know whether we are okay or not. Plus, sometimes even that much time is not adequate, so you must do a diurnal control. Means you have to put the patient on medication. You have to check whether the target IOP has been reached at all time points or not. So if it has been reached at all time points, then you can sit easy. Otherwise, you have to change your medication. You can't wait for the fields to deteriorate. Actually, if the fields deteriorate, you have already lost the battle, because some of the fibers are already dead, which cannot be brought back. So not only will you look at the pressures, you will also look at the variation. So we are trying to keep the variation as low as possible. And now they say less than 3 to 4 millimeter is the one that we'll be looking at. That is why we want to do a diurnal fluctuation initially and then a diurnal control left. So now we are going to start a medicine for our patient. First, you must sit down with the patient, spend 5 minutes, see who the patient is. Can he afford what you are giving? Where does he work? Is it possible to put him the medicines multiple times? All these factors you have to understand when you sit with the patient and talk for 5 minutes. Just talk anything. Indian people are so good, they will talk to you about everything and they will tell you, oh, I've got 3 daughters, they are all unmarried, I have to marry them off, I have no money and this and that. So you know that possibly instead of PG analog, you can start with a beta blocker. Because you know if you give an expensive drug, they will also always neglect themselves and spend the money on children. So please be careful about these small things. So what medicine I want? Something that lowers the pressure maximally, has to be put minimum number of time, preferably does not require a cold chain, which also helps me to blend the diurnal variation. But cost effective and minimum side effects are very, very important, along with effectivity throughout 24 hours, and especially in the night, because we know there are a number of medicines which do not act in the night. Now, since we do not know whether he's a fast progressor or not, you will be extra alert if cornea is on the thinner side, less than 500 microns. If the patient has a family history, and people tell me, sir, there is a family history. Arey bhai, family history is not important. Ask them what happened. Bring the records of that family person. Now, when they bring the record, you find it's an ocular hypertension, you are not so worried. But if that record shows you that the patient is already gone blind in one eye, you are very worried, because this relative may mimic those things. So if the gonioscopy is on angle closure, you know you have to be extra alert. If the IOPs are on the higher side or larger fluctuation, you are alert. If there's a pigment dispersion, pseudo-exfoliation or other systemic diseases, you are extra alert. Like we said, the primary drug would be a PG analog. If the patient is poor, you can give beta blockers. If both cannot be afforded, you can give a combination of dorzolamide and timolol, or you can give a combination of dorzolamide, brinzolamide, which may be as effective as the initial therapy by PG analog or a beta blocker. And always, if the patient is very poor, you may have to fall back on surgery. So what I have seen is people jump. The patient is 30. It is an open angle disease. So don't jump on the patient and start giving Diamox, this, that, and 10 medication. No, it is an open angle glaucoma. He has come to you after so much, but he has been having a disease for a long time. So quietly start one therapy, see how much it is effective. If the effect of one therapy is less than 15 to 20% of lowering, then you can first switch that into the same group, so that if one group is not acting, you can go on, like suppose in the PG analog itself, there are multiple choices and you can change those choices and see which is effective. If they are not working, then you can add on medication. Yes, but if the intraocular pressure is more than 30, if the disc is compromised, then I'll be okay with you starting more than 2 medications at a time, and sometimes even 3. If the pressure is more than 40, nothing is getting into the eye because the pressure is so high. So drops you will put will not use. So start acetazolamide over there or a glycerol if they are allergic to sulfas, and be very, very careful there. And again, you can add medications according to what you want. My preference for adding a second drug has shifted from brimonidine to dorzolamide, brinzolamide, simply because brimonidine does not act in the night, and brimonidine has a lot of allergy. Almost 30% of the patient will be allergic to that. And now we are lucky, there are more and more drugs like ROCK inhibitors have also come in. So you can check which one to add. Again, if it is a patient of acute ACG or acute and chronic, be more alert because ACG blindness is 3 times the OAG blindness. So you have to see them very, very regularly. And the choice, as I've already told you, depends on mechanism of action, efficacy, target IOP to be achieved, preservatives or preservative-free medications, and yes, in India, cost is very important. So see the overall picture, see the safety, see the systemic diseases that the patient is suffering from, and what is the interaction of medications that you are taking. See whether they are going to adhere and what is their quality of life. Invariably, most of the patient would be requiring more than one medication. And by the time they come to me, Manish or Sachin, they will be requiring multiple medications. So the second therapy must be carefully added, and wherever required, please add combinations about which Rajul will be talking in detail. But just to stress the point, we are putting lesser number of drops, we are putting lesser number of times, your cost is better, your exposure to BAK is better, and the chances that the patient will forget the second drop is also less. So combinations are very welcome, not as a first line therapy, but yes, at times if PGR analogs are contraindicated, maybe as a first line therapy as well. So when as a first line therapy, if there is advanced glaucoma, if there's a younger patient requiring aggressive treatment, if there's a higher rate of progression, or the fields are quite defective. In these situations, you have to be very alert. And like I told you, as far as the follow-up is concerned, if the patient is very advanced, please see that the pressures are done every month and he's followed up every 3 to 4 months with visual fields. If it is just an ocular hypertensive or very early changes, don't panic the patient. See them every 3 months for pressures and every 1 yearly for the visual field changes. Please sit with them, talk to them, explain what is glaucoma, explain to them that this is the schedule for follow-up. Please explain to them punctal occlusion, which very few people are telling. Need to report side effect, but the biggest benefit would happen when you tell them that I will take care of you. Don't go to the Google Baba and read all nonsense. So the most important part is healing. Tell them there's nothing, I will take care of it, but you have to promise me that you will come to me regularly. Thank you very much for your